I'm Dr. Otoma Gift. I'm a medical officer at this facility. So today we'll be talking about benign prostate hyperplasia, which is a common condition, especially in the male. It is a male condition in the elderly. According to the Kenyan Urology Association, one in 3 men will suffer from this disease in their lifetime, and 1 in 10 men born in this country will have to undergo an operation to help solve this problem. So what is benign prostate hyperplasia? Benign prostate hyperplasia, this is a condition that affects the prostate. Prostate is an organ that is found in the male genitourinary system. This prostate helps, why is it there? The prostate helps in, especially during ejaculation. There are some fluids that are produced from the prostate that help nourish the sperm. The fluids that are produced from the prostate also, they alkalinize the acidic vaginal fluid, enabling the sperm to swim. And then there's an antigen or a protein that is produced in the prostate called prostate-specific antigen that hydrolyzes, or what we call makes into a liquid form the semen, which is usually gel-like, so that the sperm can easily swim. That is the function of the prostate in the male genitourinary system. So you find that this prostate, there are 2 phases in which it spikes in its growth. During the first spike is during puberty, when the male organ system are growing, and then the second stage of growth is from 25 years, and it continues to grow until the end of life. And now the problem comes in during this second growth phase, because the prostate will continue to grow until it reaches a time when it now starts causing problem between around 50 years, from starting about 50 years. And you find that in men between 50 and 60 years, 50% of them have benign prostate hyperplasia, which is just an overgrowth of the prostate gland. And then above 60 years, about 70% of men, and above 80 years, 90% of men will have this problem. So how does it present? What are the signs? What are the symptoms of benign prostate hyperplasia? The first thing, it starts with what we call irritative symptoms. There's something we call irritative symptoms or lower urinary tract symptoms. And these include what we call urgency. Urgency is the inability to hold on to urine when you want to urinate. Like you feel like you have to rush to the toilet. The other irritative symptom that we have is frequency. You have to go to the toilet every time and again. The other thing is nocturia. You find that this male now, they can't sleep throughout the night. They have to be waking up several times during the night to go and urinate. The other sign of this problem is that what we call obstructive symptoms. Obstructive symptom is when you urinate, and after urination, there's some urine that remains, what we call a dribbling. After you urinate, there's some urine that continues to come out even after you felt that you finished urinating. And then there's an incomplete feeling of the bladder emptying. You empty your bladder, but then you feel like there's some urine that is left behind. And then the other issue is the issue with the inability or difficulty in starting to urinate. It means that you feel like going to the loo. When you go there, you want to start to urinate, but there's hesitancy, what we call hesitancy. Like you will take a few minutes before the urine has to come out, and sometimes you have to force it. And then after you force it, you realize that the stream is very weak. It's no longer as strong as it was, and even the caliber of the urine that comes out is a bit small. And then after you've urinated, the stream is weak. Then after you've finished, there's still some dribbling. When you realize that you have these symptoms and they have started, you have to come to the facility immediately so that we can give you advice on how to live with the condition, on how to manage the condition. Ideally, a man between 50 years and above 50 years, you have to start what we call prostate exams, regardless of whether you're having symptoms or not. You have to come to the facility for what we call prostate exams, for the simple reason that there is a condition that we call prostate cancer, that is a serious disease that has to be screened. And prostate cancer is not the same as benign prostate hyperplasia that we're talking about today. Maybe to try and prevent the occurrence of benign prostate hyperplasia, there is a lifestyle that you can adapt at home, and that is one, you avoid a lot of fatty foods. You have to avoid a lot of fatty food. Try and reduce your weight. Try to be active. Then you have to avoid things like alcohol. So when you arrive, and then you are a patient, as we see every other patient, you arrive, the first thing we do is we take what we call a history. History is we find out more about your condition. We ask questions about the symptoms. We ask questions about any concurrent disease that you have. We ask questions about, there's something we call International Prostate Symptom Score that we score you with. Then after that, after the history, then we do what we call examination. But before we do the examination, we have to do what we call a prostate-specific antigen test. Prostate-specific antigen test is an enzyme that is produced by the prostate alone. So we send you to the lab, you do the PSA. Because one of the physical examinations that you are going to do is what we call a digital rectal exam. And once you do that, it can interfere with the levels of PSA. So to give us accurate results, you have to go and do the PSA first, then you come and you continue with other physical examination, which will include a digital rectal examination. After the physical examination, which will also include a neurological examination, so that we find out, especially people come because of urine retention or inability to pass out urine. So you have to find out if it's a neurological issue that is different from the BPH, the benign prostate hyperplasia. So we do other neurological examinations. After that, then if we found out that it is most likely BPH, then there are some imaging tests that we can do. And the first imaging test that we do is what we call a prostate ultrasound to determine the size of the prostate. And then there are other measures, there are other tests that we can do, what we call a uroflowmetry. We determine how fast your urine is flowing out. And then there's what we call a pressure flow urodynamics. We determine the amount of pressure with which your urine is coming out. Okay, one is benign prostate hyperplasia is a condition that affects solely men above 50 years of age. Now the age is very, very important because the prostate grows over time. And two, the other conditions that look like BPH, we have prostate cancer that can be there. We have what we call prostatitis, which is just an infection of the prostate. And we have, you can have what we call strictures in the urethra, which can also block passage of urine. You can have bladder stones. There are stones that can also block passage of urine. Yes, and then you can have a neurological issue, a nerve issue, or probably there are medications that you might be taking that might also prevent or hinder the passage of urine. When you delay coming to the hospital, one is the ability, if it was prostate cancer, then the ability to detect it early will be hindered. Two is that your quality of life will be severely affected. The number of times you have to wake up in the night to go and urinate will really affect your ability even to interact socially, because you'll be at some point, you'll be probably in the market, and then you are having what we call incontinence, where you cannot hold on to urine, and then urine is passing down your trousers. Yes, so it will severely affect your quality of life. When you come to the facility, there are drugs that we can give. There is what we call medical management, and then this condition can go to a level where we'll have to do what we call surgical management. So in medical management, there are 3 classes of drugs that you can give. There's a drug we call alpha blockers. There are drugs we call alpha blockers. What do these drugs do? These drugs, they help relax the muscles of the prostate. They help relax the sphincter of the bladder, and it will allow passage of urine. Some of the alpha blockers that we use is what we call tamsulosin. We have what we call alfuzosin. You can have terazosin and doxazosin. But in the choosing of these drugs on the alpha blockers, what we use is your blood pressure. How is your blood pressure? Is your blood pressure high? Is your blood pressure normal? If your blood pressure is high, then we will prefer using the doxazosin, terazosin. But if your blood pressure is normal, then you are going for tamsulosin and alfuzosin. The other class of drug that that is the first line drug that you can use. The second drug that you can use is what we call 5-alpha reductase inhibitors. 5-alpha reductase inhibitors. 5-alpha reductase is an enzyme that converts testosterone to dihydrotestosterone. And this dihydrotestosterone, what it does is that it causes the overgrowth of the prostate. So this drug, the drug that we are giving, is inhibiting this enzyme from flourishing, so that we stop formation of dihydrotestosterone, which causes prostate hypertrophy. So, but before you give you 5-alpha reductase inhibitors, one thing is that we have to do a PSA, your prostate-specific antigen. If your PSA is above 1.5 nanograms per milliliter, then we can give you. And then you have to do an ultrasound to determine your prostate size. If the prostate is above 30 centimeter cube, then we can give you this 5-alpha reductase. Because what is the function of 5-alpha reductase inhibitors? It is to reduce the size of the prostate by inhibiting the hormone that acts on the prostate. So the prostate has to be large so that you realize the effects of 5-alpha reductase inhibitors. The other drug that we can give is what we call phosphodiesterase 5 inhibitors. What do these drugs do? So these drugs, these are drugs that have been used in erectile dysfunction, phosphodiesterase inhibitors. And the drug that we use, especially if you are not having issues with erectile dysfunction, the drug that we use is tadalafil. There's a drug we call tadalafil. If you are not having erectile, and if you are having erectile dysfunction, then you have to add phosphodiesterase inhibitors in the management of this issue that you are having, this BPH. You have to add the phosphodiesterase inhibitors. And then there are some drugs that you can add, but especially if your condition is so severe, what we call anticholinergics. But this one come much later, especially if you are nerve issue, you are having some nervous system problems. So those at risk for this disease. One is those people, there's what we call a family history. If your father had benign prostate hyperplasia, then it's most likely that you are going to have it. So the family history is very important. Then the second thing, if you are obese, you realize that the growth of this prostate is it becomes more, especially when estrogen in a man's body, there's a hormonal imbalance, especially with estrogen. The estrogen in a man's body increases, creating an imbalance. And if you are fat, there is an enzyme that we call aromatase in fat that takes testosterone and converts it to estrogen. So you realize that being fat and being obese is a risk factor because it will alter the hormonal levels, causing growth in the prostate. And then the other risk factor is those are the two main risk factors. Yes. Okay. And then lack of exercise will also affect you. So when you come to the hospital, there's the first thing we said, there's an IPSS score, International Prostate Symptom Score, that we use. And this score has categories. We have 0 to 7, which we call mild. Then we have 7 to 19, and then we have 20 to 35. So depending on the score, if you are scoring 0 to 7, then that is what we'll now do watchful waiting. And in watchful waiting, there's some advice that we tell you to follow. And the first advice is, one, you have to avoid taking a lot of fluids just before bed. You have to avoid a lot of fluid intake before bed or before going out. The second thing, you have to
Why?
Because of the issue with nocturia. We are trying to, it is your quality of life that we are really interested in. If you take a lot of fruit, then you're going to go to the low hours of time during the night. Yes, the other thing you have to avoid is taking alcohol and these caffeinated drinks, because it causes what you call diuresis, increase in urine flow. The other thing, you have to avoid fatty foods, things like margarine, butter. You have to avoid them. Then we will encourage you to avoid, you have to do exercise. 1, to reduce weight. 2, being active also causes hormonal balance. The medical management, as I've told you, we start with the alpha blockers, and then depending on the size of the prostate, we can add 5-alpha reductase inhibitors, and then depending on the issue with the inability to erect, we can add the phosphodiesterase 5 inhibitors. And then we observe you for over 6 months. But you are coming every month for checkup. And each time you are coming, we are taking an IPSS score. And we are observing, is your IPSS score improving or is it worsening? Then when it comes to a time when you realize that the IPSS score is not improving or is worsening, then there's a surgical management of benign prostate hyperplasia, where we go in and we remove the prostate. So, and also if your prostate is large, if your prostate is large, okay, there are several types of surgeries that we can do. There's what we call open prostatectomy that we can do, and then there's what we call transurethral resection of the prostate. So these two methods that are commonly used here will really depend on the size of the prostate. If your prostate is over 75 grams, then we have to do what we call an open prostatectomy. Otherwise, if it is below that, then we can do a transurethral resection of the prostate. But we only do that if the medical management has failed. That is on a follow-up of over 6 months, and you're not noticing any improvement. And also if there's what we call an inability, a complete inability to pass urine, then we have to do an operation. The other drug that we can give is what we call ketoconazole. Ketoconazole is an antifungal, and we can give ketoconazole together with hydrocortisone. Hydrocortisone is an anti-inflammatory, and they help also in the reduction of production of androgens in the body. And then there are some therapies in which people have received estrogen, given estrogen to try and affect the androgens, to reduce them. Then we have chemotherapeutic drugs that we can give. We have the taxanes, paclitaxel, docetaxel, that we usually give when especially we introduce the chemotherapies when androgen deprivation therapy has failed. That means that now we can use the chemotherapy, docetaxel and paclitaxel, which are chemotherapeutic agents. So with the chemotherapeutic agents, then we can introduce what we can do is what we call radiotherapy. And then especially if your prostate is localized, like it has not metastasized. When your prostate when the cancer has not gone to other organs, what we call metastasis, then we can do what we call a prostate surgery. And there's a way we usually determine whether the stage of this cancer. We usually use what we call a TNM staging system, where we look at the tumor size, we look at the nodes, which nodes are affected, then we look at the ability or if it has metastasized. Then depending on the TNM staging, we can, and depending on the TNM staging and also what we call a Gleason score. Gleason just looks at the architecture of this cancer and how worse it is. Depending on that, then we can do an operation or surgery to remove this cancer. We have some side effects that you can get when you are using some of these drugs that we give. If you're using alpha blockers, then you might realize that you'll get what we call nasal congestion. You might get, you might be drowsy. And then the 5-alpha reductase inhibitors, when you're using them, then you might have issues with libido. You can have issues with sex drive, that is the sex drive libido. Then you can have issues with impotence, that is the inability to erect, when you're using 5-alpha reductase inhibitors. And then when you are using drugs like phosphodiesterase 5 inhibitors, the likes of sildenafil, tadalafil, especially when you're using nitroglycerin tablets in management of your blood pressure, then you can have issues with your heart. So you have to avoid the combination of these drugs with phosphodiesterase inhibitors and nitroglycerin. When you have BPH, benign prostate hyperplasia, you are not at any more increased risk for prostate cancer as anyone without BPH. If you have a normal prostate, and if someone else has a large prostate, that is benign prostate hyperplasia, the risk for prostate cancer is the same. The reason being is that prostate cancer, the part that the prostate cancer affects and the part that is affected by benign prostate hyperplasia are different parts or are different zones of the prostate. We have, the prostate has what we call lobes. These are just parts that makes up a whole. We have the lateral lobes, you have the anterior lobe, the middle lobe, and the posterior lobe. So in benign prostate hyperplasia, it is the anterior lobe, part of the lateral lobes, and then the median lobe that enlarge. And these parts are not really the parts that are affected in cancer. The part that is affected in cancer is the posterior lobe. So the posterior lobe is what really is affected when you have prostate cancer. That means that when you're having BPH, that part is not even affected with BPH at that time. So when cancer comes in, it means that it can come together with BPH. Yes, you can have BPH and you can have prostate cancer at the same time. So when you come to the hospital, we will screen for that by using PSA. When there are levels of PSA that, if PSA is so high, like above 30, we are suspecting cancer, and then you have to do what you call a prostate biopsy. So BPH does not lead to prostate cancer. You have to understand that prostate cancer is independent of BPH, so independent. And then also for prostate cancer, especially at 50 years of age, we usually start screening for prostate cancer. And when you come to our facility, we do what we call a digital rectal examination, where we feel the texture of the prostate. And then depending on the texture, then we can do a PSA, which we've told you that if it is so high, we are suspecting prostate cancer. And when we suspect prostate cancer, we do what we call a prostate biopsy. A prostate biopsy is just taking a sample of the prostate and taking it to the lab, and then they look at it to determine if it is cancerous or if it is not cancerous. So you have to understand that prostate cancer is the most common cancer in males. It is the most common cancer in males. And it is, I think, the second cause of morbidity and mortality in cancer in Kenya. So when you find that you have prostate cancer, when we find that you have prostate cancer, there is the management that we can institute. There is what we call, especially when you find that when you come early and then we screen, when we screen and then we are suspecting prostate cancer, we do a biopsy. After we've done a biopsy and we see that you have prostate cancer, then there's the management that we can institute. So if you come early, the management is better, and the outcome, what we call the prognosis, is better. So when you come and then we detect it early, there's something we can give what we call androgen deprivation therapy, because the prostate is really dependent on the male hormones, what we call androgens. The first hormone that we have is what we call testosterone. Testosterone is produced by the testes. Then we have another hormone, what we call epiandrosterone, that is from the adrenal glands. And then we have what we call dihydrotestosterone, which is a conversion of testosterone. If you convert testosterone, you get dihydrotestosterone. But you convert it by an enzyme called 5-alpha reductase. So there are these androgens that act on the prostate. And when you deprive the prostate of these hormones, the prostate will shrink in size and the cells will die. So when you come to the facility and we find that you have this prostate cancer, the first thing we'll give is androgen deprivation therapy, which also can be termed as castration. We castrate you, but medically. Because castration is just the removal of testosterone. removing testosterone is the same as castration, because testosterone is produced from the testes. So physical castration will remove testes, will remove the testes, no testosterone. Medical castration, we will hinder that testosterone, and the effects are the same. So some of the drugs that we use is what we call flutamide. We have flutamide that we can use in prostate cancer. With the flutamide, what does it do? It prevents the conversion of the androgens in the adrenal glands into, it prevents formation of androgens in the adrenal glands. So if you realize that you have these symptoms, you can come to this facility. We have doctors that can, we can come to this facility, Shewe Community Hospital Limited facility here at Khaega. We have doctors that can look at you, they can score your issues, they can investigate your issue, and then they can manage your issue and increase your quality of life. Yes.